you to this live program at Orthopaedic Principles. Today, our guest of honor is Professor João Espregueira-Mendes from Portugal. Professor Mendes is the clinical director of Clínica Espregueira, a FIFA Medical Center of Excellence. He's a professor at the University of Minho, responsible for orthopedics and the locomotor system. Professor Mendes is currently president-elect of the International Society of Arthroscopy, Knee Surgery and Sports Traumatology, the ISAKOS, for the period 2025 to 2027. Professor Mendes has been the past president of the ESCA during 2012 to 2014. He's also the founder and president of the ESCA Foundation during 2013 to 2015. Professor Mendes is a distinguished member of the FC Porto Advisory Board, member of the Patellofemoral Foundation Board Directors, and member of the board of FIFA MCE. He's a collaborating researcher at the 3Bs ICVS at the University of Minho. Professor Mendes also served as the president of Dom Hendrik Research Center and has been the past president of the Portuguese Society of Arthroscopy and Sports Trauma during 2004 to 2008. Professor Mendes has more than 200 international publications, 20 Springer books, and 84 book chapters. So today it's my great honor to introduce you to Professor João Espregueira-Mendes from Portugal. Over to you, Professor.
Thank you, Gopalans. It's a great pleasure to participate in the Orthopaedic Principles Program. And my topic today is to show you a new technique to reconstruct the MPFL for patellofemoral instability. This is the place where I work in the north of Portugal, in Porto, a sports clinic just inside the FC Porto Stadium. Be welcome, all of you that want to visit us. I don't have special disclosure for this presentation. So patellar instability, it's a complex disease with a lot of factors that can originate. We have an important incidence of this pathology in the athletic population, and more than 50% of the lateral dislocations occurs in sports-related injuries. The Lyon School defined very clearly a very important number of risk factors for patellar instability. The 5 major reasons why patella dislocate is the trochlear dysplasia that can be classified in several different degrees, with the severity of the C and D more important. The increase of TTPG distance, when this distance is above 20 millimeters, more than 20 degrees of lateral external tilt, and the patella alta above 1.2, together with an increased lateral patellar transluxation. Those are really the factors that matters for this instability. The problem was that we were not able to measure correctly this laxity, and that's why we were involved during the last years, and we tried to give some knowledge on that aspect of this pathology. We did this systematic review that we published in the Castor Journal, showing that there is not an instrument assessment method that could be reliable to measure this instability. And because of that, we developed this new instrument. It's a stress device that can do CT scans and MRI, and you can easily stress the patella laterally, medially, or rotate the patella so that you can see and measure the laxity. Here you can see how we do that. With compressed air in a full polyurethane device, you can stress the movement of the patella in an horizontal plane and lateral and medial. With this instrument, we try to study the stiffness of the medial patellofemoral ligament, and we tried to identify in the patellar pain syndrome what happened in this laxity. It was very interesting to see that we can have patellofemoral pain without instability, without dislocation, and we can see that the laxity of this patellofemoral ligament on the medial side is higher than normal. And so probably there is a new entity that is the insufficiency of the medial patellofemoral complex. And this is clearly what we want to address today. And this is clearly what we want to show you. How do we approach this problem? First of all, what do we do today in a first dislocation? And if there is a first dislocation, high energy, without significant instability risk factors, we do a conservative treatment. And in those patients, we can get a return to play and a return to physical activity very nice. And of course, if the situation is a combination between all the risk factors that I mentioned together with a low energy dislocation, then we need to go for a stabilization. What is classically described in the literature is that the reconstruction of the MPFL is a reliable procedure. In fact, we are going to try to show you that MPFL is not the only thing we need to reconstruct for this pathology, because we need to talk about the medial patellofemoral complex. And the medial patellofemoral complex includes the medial quadriceps tendon femoral ligament that comes from the femur to the lower part of quadriceps tendon, just on the insertion of the patella and the VMO. We have the medial patellofemoral ligament that goes from the femur to the medial border of the patella, but we also have the medial patella tibial ligament and the medial patella meniscal ligament that contribute to stability. And so in this structure, you can here see very well the position of these three: medial patellofemoral, medial patella tibial ligament, and medial patella meniscal ligament, that are part of the medial patella ligament complex, but also, like very well described by John Fulkerson, we have part of the medial patellofemoral ligament that goes to the quadriceps tendon and has an important role in the engagement of the patella. So it's something that we should reconstruct to be more anatomical. Because of that, in 2019, we described this technique to reconstruct the medial patellofemoral complex in arthroscopy journal techniques. So the surgical techniques is very easy. We do 3 incisions on the medial patella border, over the adductor tubercle, and on the classical position to harvesting the hamstrings tendon. And for this technique, we need to harvest the 2 tendons, the gracilis and the semitendinous. As you know, they are very long. We can go up to 22 centimeters long. So very easy to use to this technique. After that, we isolate the adductor tubercle. We need to dissect this structure so that we are able very easily to pass some stitches below it, and to identify it very well is the region that we are going to use to stabilize our graft on the femoral side. This technique doesn't use tunnels on the femur, doesn't use tunnels on the patella. So it's a technique that just stabilizes the ligament part. And with that, we need to be very distal on the tendon so that we are very, very close to the anatomic point of the insertion of the medial patella ligament complex. Then we do a medial approach. In this case, we do a large medial approach just for didactic purpose. Normally we use a small incision of 5 centimeters, and we are going to do small incisions in the medial retinaculum, inferior third of the patella, superior third of the patella, and a third opening in the retinaculum just near the quadriceps tendon and the VMO. because we are going to do a reconstruction of all these three parts of the medial patellofemoral complex. Then with the forceps, on a classic way, we pass through the subvastus space without violating the intraarticular space, just to use this passage for our grafts. Then we are going to pass our grafts, the gracilis and the semitendinous, around the adductor tubercle, and they are not going to be sutured there. They will be flexible. They can slide on the adductor tubercle, and we pass these four arms, two arms of the gracilis and two arms of the semitendinous, to the medial border of the patella. Here you're having the second one, and again passing it to the lateral side, to the medial part here, to the quadricep tendon. So we have two arms together on the quadricep tendon, and we use the gracilis for that, and two arms separated from the semitendinous to reconstruct the MPFL. After that, we are going to pass them through the retinaculum, and we are going to suture these grafts, and we want to suture them and to tension them in full extension. Is the best way to give some movement to the patella and to avoid excessive stiffness of the graft. And after suturing, we use the fiber wire because we want to be sure that the suture stands. So we don't use reabsorbable suture. We use a fiber wire, and we do the suture of the two arms on the patella and do the two arms together on the quadriceps tendon. So at the end of the day, we have a very large reconstruction of the medial patellofemoral complex with the ligament to the quadriceps tendon reconstructed with the gracilis, and the real MPFL with two arms reconstruction on the medial side of the retinaculum. And with that, we make the simulation more anatomic and more close to real anatomy. What are the advantages of this technique? So first, we get the reconstruction a quasi-anatomical point, more reliable than the shuttle point, because the adductor tubercle doesn't change, we don't have the risk of the surgeons to do a mistake. We do this technique without any radiography, so we avoid X-rays in this technique. We provide a strong fixation, but we don't do bony attachment, so we avoid over-tensioning and overloading the joint. The nice study of Vicente Sanchez Alfonso with finite elements show that this point give us a very nice distribution of the pressure on the cartilage, so very anatomic and very reliable for the biomechanics. And we can do that in open physis in kids because there is no risk. We don't have bone tunnels. We don't have the risk of the patella iatrogenic fracture. We don't use anchors or screws, so less costs. And it's more reliable than the shuttle point, no radiation, and we can add other bony procedure. Of course, that we need to do other bony procedure before this procedure. So this is really a nice technique that can be an option to treat the dislocation of the patella. So take-home message. We need to pay attention to the anatomic risk factor, very well described by the Lyon School. It's very useful to measure with an instrument the laxity and the joint stiffness. Portopatellar testing device is a nice solution. We are conservative in high energy first dislocation, no risk factors of dislocation, but we are more aggressive in patients that have a lot of risk factors. Recurrent dislocations must be treated surgically, and we suggest this reconstruction of the medial patellofemoral ligament complex to be more anatomic and to have low risk of patellofracture, no use of hardware, no use of X-rays, and a more reliable femoral fixation point. Thank you so much, and be welcome to ISAKOS in June.
Thank you very much, Professor. Prof, you can stop sharing actually.
It was okay?
Yep. No, you can close it. Yeah,
Oh,
close
well.
it. Yeah.
Oh, well.
Thank you very much, Professor, for this very great presentation actually. And congratulations for being elected for ISAKOS as well.
Thank you so much. Thank you so much. It was a pleasure to be with you, and thank you for the invitation to participate in this nice program.
Thanks again, Prof.
Few questions, Prof. Prof, very commonly we do the MPFL or the MQTFL reconstruction, right? So do you think it's an overkill to use both? So can we just get away with one procedure alone?
If I can get you well, you are asking if MPFL alone is enough to do
or MQTFL, either of those.
Normally, if we have too much risky instability, if you don't have many risk factors, you can do one alone. But if you have a very important tilt and you have the information that on the engagement of the patella, the engagement is happening wrong, then you need to reconstruct the proximal part of the quadriceps femoral ligament. Otherwise, you don't control so well the engagement. And of course, if you control the two, it's better than to control one alone.
Thank you very much, Professor. And Prof, do you add any other adjuvant procedure along with it? For example, do you add a tibial tubercle osteotomy if there's a patella alta or an increased TTDG distance?
The strategy to approach this pathology is the Lyon strategy, is the menu à la carte. So we need to correct what is wrong. And of course, if you don't correct the patella alta, it will be impossible to get a good result on your stabilization. And also the same to the medialization of the tuberosity. You need to correct, if the TTGT is above 20 millimeters, you need to correct that. The question is, you need to do it before, because if you lower your patella after the medial reconstruction, then you lose the tension on the medial reconstruction. So do this bony procedure before, and then do your medial patellofemoral reconstruction after. The same to the, if needed, in the very severe cases of tracheoplasty. You need to do everything before, and then at the end of the day, you reconstruct your medial patellofemoral complex.
Would you state, sorry for that, for the stoppage.
Prof, we're also joined by Loy. Loy Al-Khatib is an orthopedic surgeon based in Dubai. Loy, your questions to Professor Mendes, please.
Thanks again for the nice presentation, a nice technique actually. I think we have three techniques, let's say. The MPFL, the original one with 2 limbs, the MQTFL without limbs, and there's a hybrid technique. If you compare those three techniques, you will find that the patellar translation is least with the MPFL compared to the MQTFL, and the hybrid technique will come in between.
Yes.
Would you save the MPFL reconstruction for more severe cases? This is one. And why do you think we need to shift to the MQTFL? Is it more anatomic? Because one of the studies showed that it's not about only the single MPFL itself. This is an MPFL complex, which most of the incision site comes from the distal quads tendon. Because that's why then the people that are now shifting to do the MQTFL. The other one, the last question is, we were talking, me and Hitesh were talking about just taking the distal third, let's say for the quadriceps, and reroute it to the shuttle point. Wouldn't that be enough as well?
So first part, very interesting. When you do an orthopedic procedure, and you in the history of orthopedics, you are not anatomic, the history show you that you were wrong, and that you shift to a more anatomic procedure in a moment of the history. And so if we have a medial patellofemoral complex, large, that goes from the quadriceps tendon to the lower border of the patella and even to the tibia and to the meniscus, the more anatomic you are, the more fibers you have replicating the normal medial patellofemoral complex, the best. And John Fulkerson showed that very well, the importance of the medial quadriceps tendon ligament, especially on the engagement, because after you have the patella engaged, everything is on your favor because you have a rail that conducts the patella. But before that, you need to control rotation. For the second question, my problem with the quadriceps tendon is the overpressure. If you twist the quadriceps tendon, of course that you are going to increase the compression weight on the patellofemoral joint, and you are not able to control so well those forces. So you can do it, yes, you can do it, but it will be more easy for you to make a mistake on the tension than with the other technique of the reconstruction of the medial patellofemoral ligament complex.
Agree, nice. The other question maybe still not answered yet. It's about lateral release. When and when not to add the lateral release, how much you release, avoid over release, and the other thing is tension. Do you think we don't have any objective measure to measure the tension that we apply on this MPFL complex? If you go back to the biomechanical studies, these studies will show you need at least 2 Newton. But in the operation in the theater, what is 2 Newton? Is it that much following it, or is it slower? Or do you have any tips or tricks for, especially for the beginners who they're starting doing the MPFL reconstruction?
If you have the Portoni testing device, it will be easy for you to do it.
So you can sit one
you stress the patella medially, and if you have a reduction, you don't need any lateral release. The patella is able to go with your correction to his place, to his anatomic place. The problem is that when you don't have that, you need to test it with your hands, with your fingers, and to see if there is reduction. Why to have a lateral release if you have movement of the patella? Another different topic is the patellofemoral osteoarthritis, where you have stiffness on the lateral retinaculum. On the patellofemoral osteoarthritis, you need to release, otherwise you are not able to correct the position. But normal in young people with a patellofemoral dislocation or instability, the patella is very mobile, and you don't need to do a lateral release. And for sure that you should not do a lateral release as an isolated procedure. This is something that we need to stand for. We should not do a lateral release alone to align a patella.
It's outdated. Hitesh, I think we need to give him a visit in Porto. Let's go in summer.
Of course. Thank you very much, Professor. I think that, yeah, I think that's all the questions that we have for this session, Prof. Thank you for this fantastic presentation, and best wishes for your ISAKOS in Boston.
Thank you so much. See you in Boston, but if you want to come to Porto before, you will be very welcome.
Thank you.
Thanks a lot.
Thank you.
Cheers.
Bye-bye.
Take care. Bye-bye.
Bye-bye.